morning CME. And before we get started with this morning's CME, I hope everyone is doing well. And we have a sponsor with us this morning, and our sponsor for this morning's meeting is Viatris. And if you look on the screen, you will see some of the products that you will be very familiar with that Viatris promotes in the Bahamas. And with us this morning, we have Ms. Gia Ferguson from Viatris, who will be telling us a little bit about one of her products. So you can go ahead, Gia.
Okay, good morning, everyone. I trust you all are doing safe and keeping safe during this time. This morning, I am going to detail you on Lyrica. Lyrica, for the active ingredient, is pregabalin. And in this market, we have 4 different strengths available for you. The indication for Lyrica is for your neuropathic pain patients, patients with generalized anxiety disorder, and as well, it can be used as an add-on therapy for patients with epilepsy. We have the 25 milligrams that have been recently introduced into the market, and it will be for your patients with renal insufficiency, and it can be given according to their creatinine clearance. We also have the 75 milligrams that's available on the government tender, and the therapeutic dose for Lyrica would be 150 milligrams per day, which would be the 75 milligram capsule twice daily. After 3 to 7 days, you can then titrate the patient up to the 150 milligram capsule twice daily. And then you also have, after another 3 to 7 days, the 300 milligram capsule twice daily, which will bring it to a max of 600 milligrams a day. So pregabalin improves the quality of life. Neuropathic pain is generally associated with other debilitating conditions that affect the quality of the patient's life. Patients who are experiencing pain, 60% of them may develop anxiety, and another 50% can develop sleep disorders. These associated comorbidities can affect how they are experiencing pain. So what Lyrica does, it helps in the treatment of all of the elements of the pain triad and improve the quality and life of the patient. Therefore, they'll have less pain, less anxiety, and they're able to sleep better. The benefits of pregabalin is associated with a fast and significant reduction of pain since the first week. Again, it will improve your patient's quality of life. Lyrica has very flexible dosing, mild to moderate adverse events, which resolve after the first 7 to 10 days if they are experiencing any adverse events. And Lyrica also has very low potential of pharmacokinetic interactions with other medicinal products. So it's especially safe for your elderly patients. Efficacy in the treatment of GAD. So pregabalin is also comparable to benzodiazepines for the treatment of generalized anxiety disorder. So this is something that you can use on your patients who are experiencing anxiety. You can start them on the 75 milligrams therapeutic dose, which is twice daily, and you can increase it as needed. Pregabalin also shows a better safety profile than benzodiazepines with a significantly lower abandonment rate. So please remember that Lyrica will improve the patient's quality of life, has very flexible dosing, mild to moderate adverse events, and very low potential of drug-to-drug interactions. Thank you so much for having me.
Thank you very much, Ms. Ferguson, and we will post your contacts in the chat for those that might be needing to get in touch with you. So on to this morning's CME. So it's my pleasure to introduce you to today's speaker, and today's speaker is Dr. Marc Andrew Freeman. In 2000, he graduated with his MD at the University of Toronto, and then he went on to do his postgraduate training at UFT. After completing his internship, he specialized in diagnostic radiology and nuclear medicine. He also holds certification with a fellowship in the Royal College of Physicians and Surgeons, nuclear medicine, and a fellowship in the Royal College of Physicians and Surgeons, diagnostic radiology. He also holds licensure with the American Board of Radiology. Presently, he serves as the Chief Medical Officer at My Health Center in Toronto and he is the staff radiologist and nuclear medicine physician at PET CT International, Nassau, Bahamas. He has previously served as physician lead, nuclear medicine and molecular imaging, staff radiologist, director, assistant professor, director of nuclear medicine, and a residency program and lecturer. One of his many honors is his excellence in teaching from the Department of Medical Imaging and Residency Program at University of Toronto in 2010-2011. From 2017, he serves as the chair for clinical practice parameters and facility standards and nuclear medicine working group, College of Physicians and Surgeons, Ontario. Two of his most recent research endeavors are PET CT for the diagnosis of recurrent cancer, a feasibility study, and he was the principal investigator on this. And he also did PET for the investigation of solitary pulmonary nodules in biomarker positive and anatomical imaging negative thyroid, germ cell, and colorectal cancers. He has 15 publications and has presented at numerous special lectures and has been involved in teaching and design. It's now my pleasure to welcome Dr. Freeman to speak with us today. Welcome, Dr. Freeman.
Thank you so much. Thank you very much for the really great introduction. Just want to say it's an honor to be presenting to this group today. Thank you for the invite, which came through Dr. Tracy Roberts. Really appreciate it. I'm very excited to present to you a very important imaging modality now available on site or locally to the patients in the community of the Bahamas. So I'm just going to share my screen here. Okay. So again, thank you for the great introduction there, Dr. Black. I have no conflicts of interest. But what I would like to do is I would like to acknowledge just a few people before I begin. Dr. Wesley Francis, who linked up with me several years ago regarding about the opportunity to interpret PET-CT from the Bahamas. I'd also like to acknowledge the great staff at the PET-CT International facility in NASA as well as the group of physicians there who send their patients to that facility. What I would say is that the work that I've been doing at the facility now for 2 years now is probably the most challenging work that I've had to interpret in my 15-year career. But what I would say that it's the most satisfying, and I hope you're finding it very impactful for the patients in the community in the Bahamas. So this is about a 45-minute presentation. I'd like to save some time for questions at the end. But there's just a quick brief outline. So I'm going to discuss the basic principles of FDG PET and this amazing technological modality. Then I'm going to go through some of the indications and applications for PET-CT in oncology, which is the prime driver and a prime user for this imaging technique. And then finally, I'm going to show you some cases which I believe have significant impact from patients in the Bahamas utilizing FDG PET-CT at PET-CT International. There's going to be a lot of references to Canadiana here. My favorite hockey team is the Toronto Maple Leafs, and this is the holy grail of sports trophies. It's the Stanley Cup. So there'll be a lot of references to that as well. So Dr. Black just introduced me. So who am I? That's a sort of very philosophical question. So I did a degree in biology at the University of Western Ontario, which is about 2 hours southwest of Toronto. And for 10 years, I did medical school, a radiology residency, a nuke med residency at the University of Toronto. For the first 6 or 7 years of my career, I worked at University Health Network, which is the largest teaching-based hospital in Canada with over 1,300 beds, where I was division head and program director for nuke med, and I call that the Imperial Empire. 7 years later, I was rescued by the rebellion and worked at a large, one of the largest community-based hospital networks in the country, Trillium Health Partners, which is a 750-bed hospital, and that serves about 1.2 million residents just adjacent to Toronto. And then for the past several years, I've been Chief Medical Officer for My Health Centre, which is the largest outpatient subspecialty and diagnostic center in Canada.
Dr. Freeman, my apologies for interrupting you, but if you're sharing your slides, we're not seeing them.
Ooh. Oh my goodness, I don't see it. Let me, excuse me for 1 second. Let me try that again. How's that?
Yes, we see
Perfect.
them.
Perfect, perfect, perfect. That's great, thank you. And currently I'm Chief Medical Officer for My Health Centre. So this is Toronto. Toronto has a population of over 6 million in the Greater Toronto area. And just here's a little bit of Canadiana. Our national animal is the beaver. If you know some Canadians, they tend to say a lot. So that's very Canadiana. Two homegrown celebrity talents from Toronto are Drake and Justin Bieber. One of the most important discoveries that was done in Toronto is the discovery of insulin by Banting and Best. And another very important discovery that happened actually in Toronto as well was the invention of peanut butter. So now what we're doing is we're going to go back to the future. We're going to go back in time to discuss a little bit some very important events that happened about 50 years ago. So in 1953, the Dow Jones Index was 266. On March 1st, 2021, does anyone have any idea what it is now? It's about 30,932. In 1953, Queen Elizabeth was coronated the Queen of England. And this is the Queen today, looking pretty great many years later, but she has to deal with a bit of a royal mess with Kate and with Meghan. On April 2nd, 1953, a very important article was published in Nature. It was published by Watson and Crick. And the title of the article was Molecular Structure of Nucleic Acids, and they delineated the structure of DNA. In 1953, there was a very important Nobel Prize given in physiology or medicine. The person who received that prize was Hans Adolf Krebs, and he discovered the citric acid cycle, something that many of us learned in biology in high school. And in 1953 was actually the birth of PET-CT, and that was invented by two scientists in the US, Bronwell and Sweet, and they developed the first clinical positron scanner. So this is actually the scanner that you see here. The patient's actually, their head is in between two rectilinear detectors. And this is a patient who had a brain cancer, and they were actually detecting for that lesion. And if you can see, this is the right side of the head. This is the left side of the head. And there's increased activity on the left side. And that was detection of the brain cancer. The radioisotope that they used was actually arsenic. That's a little oh my God emoji there, but they used that because it was a positron emitter, and it went to areas where there's disruption of the brain-blood barrier. And in April 5th, 2019, 66 years later, a very important event happened in the Bahamas. And that was the first PET-CT scan. So 66 years after the invention of the positron emission technology, the first PET scan happened in the Bahamas. And 2 years later after that, on April 5th, 2021, this is 68 years later, the temperature in the Bahamas was 82 degrees Fahrenheit. And my kids were playing hockey on a frozen lake in the Canadian tundra. So many important events happened over the last 60 plus years. So now what I'm going to do is I'm just going to go quickly through some very, very basic physics and chemistry regarding PET-CT and radiopharmacy, to just give you a better understanding of how the technology works. So whenever you're dealing with radioactivity, it can come from many different ways within the atom. It can either come from the electrons outside the nucleus, and that's how X-rays are made. So basically, what happens is that electron on the inside of an orbit is ejected, and then an outer orbital electron moves down into the inner orbital electron place, and then it emits an X-ray because of the differences in energies. In nuclear medicine, we deal with radioactivity inside a nucleus. So if you have an unstable nucleus, it can emit a gamma ray, and those gamma rays are what we use when we image patients on bone scintigraphy or anything with nuclear medicine. There's also different other ways to decay, and which are related to particles. So you can have an alpha particle decay, a neutron decay, or a beta decay. And PET-CT works with beta decay. So these are nucleuses which have lots of protons. They're very unstable. And in order to stabilize, what they need to do is they need to actually eject a positron to neutralize all the positive positivity within that nucleus. So the isotope that we use in PET-CT is F18, and F18 is a positron emitter. So again, F18 has lots of positrons inside the nucleus. It needs to become more neutral. So what it does, it decays, and it releases a beta particle, positive particle, and that's a positron. And positrons, they don't like to live by themselves for very long. So what happens then is that they travel a very short distance from the nucleus of F18, and they encounter an electron, and that's sort of an instantaneous attraction. And when those two beta particles and beta plus particles and beta minus particles link up together, they create two gamma rays, which are 518 keV, and they're emitted at 180 degrees, is what you see there. And in PET-CT, what we're doing is we're actually detecting this 511 keV gamma ray, coincidentally on both sides to localize an event that's happening from the injection. So what is like FDG? Well, FDG is just basically radioactive sugar. And what has done in the production of FDG is that this is the normal structure of glucose. And normally the hydroxyl group is placed on the 2' position. But what's happened with to create radioactive glucose is that 2' position hydroxyl group is removed, and F18 is added to that molecule to make it radioactive. So this is radioactive, basically it's just radioactive sugar. Let's talk a little bit about the production of FDG. Let's not talk about too much about it, but basically what happens is that the isotope F18 is created, and through a very complicated process in a cyclotron, and through a secondary ancillary production process, you put F18 in, and what you get out is F18 FDG. And that's the isotope that we use probably as the biggest bang for your buck in patients with oncology, and the agent obviously that we're using in NASA and the Bahamas. So where do we get F18 FDG for the PET-CT International Facility? Since there's no cyclotron in the Bahamas, the pharmaceutical has to be obtained from the US. So this pharmaceutical comes from Fort Lauderdale. So it travels about 300 kilometers when there are scan days, all the way to the airport, and then the pharmaceutical is then logistically driven to the facility. Now it's basically a race against time here, because this product that we've created has a half-life of 110 minutes, or close to 2 hours. So the way you have to think about it is that every 2 hours you have half the amount of radioactivity to inject in a patient. So if this trip from Fort Lauderdale to the facility takes 3 to 4 hours through all the logistics, you're dealing with 1/4 of the radiopharmaceutical that was initially produced on production. And then if you have a patient later on in the day, 4 to 5 hours later, again, you're dealing with 1/16 of the radioactivity. So it's very important, obviously, that the logistics and the travel isn't delayed, and that the patient workflow within the facility is in such a manner that there's no delay, because the worry that there would be is that you don't have enough radioactivity when you're injecting your patients to produce very optimal scans. So what's the biological basis for F18-FDG in a tumor cell? Well, tumor cells are highly proliferative and they love glucose. And so what tumor cells have is they have glucose receptors on their cell membranes to transport glucose inside the cell, which can be used for cell division. Now there's an upregulation of those glucose receptors on the cell membrane. So if there's more receptors, there's more glucose coming in. And if we're injecting radioactive glucose, FDG, that's also going to be upregulated into that cell and be taken up. So there's an upregulation of these glucose transporters. So it's an upregulation of FDG. And there's also an upregulation of an enzyme, which is hexokinase, which phosphorylates glucose. So there's an upregulation of that. There's an upregulation of this phosphorylated FDG in the cell, and that actually can't go by across the cell membrane. So more glucose transporters, more enzymes involved in glycolysis, more uptake of cancer cells with glucose and then radioactive glucose. So let's talk a little bit about PET-CT. Now, so PET-CT is a hybrid type of imaging. It's a cross between a PET scanner, which is a scanner used in nuclear medicine and for gamma ray detection, and a CT scanner for anatomic localization. So this is a hybrid here. This is a hybrid right now. This is one of the first hybrids on the market, the Toyota Prius. And again, it's a car that has sort of the best of both worlds, fuel efficient, but also uses battery for part of its power. This is another hybrid here. This is a mule, and a mule is a hybrid. It's a cross between a donkey and a horse. It's a horse because the horses are very strong, and a donkey because it's got great longevity. The big problem with this hybrid is that it's sterile. This is a hybrid golf club. This is my golf club that I use on the course. It's a Sumo Squared from Nike. And it's great because it gives you great ball speed. The head's a bit offset, so you get maximal distance, and it's got great forgiveness. And probably the most famous hybrid of them all, and I'm a big Star Trek fan, is Jean-Luc Picard when he was made part Borg, so part machine. And this is Lakutis of Borg, who's probably, again, one of the most famous hybrids out there. So this is not what our PET-CT scanner looks like. This is Arnold Schwarzenegger, and another big fan I am in Total Recall. So the technique is not this agonizing at all. So the question is why do we need hybrid imaging? And another famous hybrid as well is Spock, half Vulcan, half human. And what he's doing now is a mind meld. So this is the first and probably last bit of trivia that I'm going to give for all you Star Trek fans out there. So the quiz here is, which of the following beings is the most impervious to the Vulcan mind meld? Is it A, this is Horta, an organic creature from Janus 5? Is it a blue whale from Earth? Is it a robot from Earth that was sent out in space many years ago? Or is it a Ferengi? So which of the following is impervious to the mind meld? Horta, blue whale, Ferengi, or robot? So this is Spock mind melding Horta in 1967. One of my favorite movies is Spock mind melding a blue whale in The Voyage Home. And this is also another mind meld of the robot. So the answer here, if you look at their Wikipedia, is the Ferengi. So the Ferengi are one of the few races known to be impervious to the mind meld. Mentally disciplined Cardassians and Kardashians may also be resistant to mind melds as well. So this is a good little piece of trivia if you're ever having a party and you want to talk a little bit about Star Trek. So this is what Nuke Med looks like. It's basically a universe with lots of dots. And this is what we're looking at. We're looking at lots of dots, not great resolution, but really great sensitivity. So this is how a normal Nuke Med scan would look like. So let's assume that we want to find NASA in this entire large volume of space. Well, what we can use is we can use a radio tracer that's very selective for NASA, F18 NASA, and we can sort of figure out what galaxy it is. So we think sort of a submarine here, but we're not actually sure. But now if we add CT, we can basically pinpoint the exact location of NASA. So that's basically like our Hitchhiker's Guide to the Galaxy. It tells us exactly where this radio tracer, where this tag has been has gone. Now, how do PET scans and CT scans, like how do they complement each other? Well, a CT scan is not very sensitive, but it's got great spatial resolution, so we can see very small things in the 1 to 2 millimeter range on CT. A PET scan has a really terrible resolution, but it's very sensitive. So by combining these two modalities together, we get the best of high resolution and increased sensitivity to detect lesions. So this is what a conventional PET scanner looks like. This is the PET scanner that we have at My Health PET CT in Ontario. And what you have is you have the CT scanner on the front, you have the PET scanner on the back, patient lies on the table, and images are taken over a period of time, and then the images are fused together, both on the PET side and on the CT side. So this is what a PET CT, these are what the images that we get from PET CT. So on the CT scan, we have the CT of the chest, and we have the PET scan, and then through software, those two images are fused together, so we get a registered images. This is a patient who had a lesion that was a juxtapolar lesion in the right upper lobe, so you can sort of see it in here. And then there was also a little lymph node high within the superior mediastinum. On the PET scan, we see hypermetabolism in that juxtapolar lesion and also in that lymph node high in the mediastinum. And then by fusing the two together, we get great co-registration so that we can confidently say that that abnormal metabolism or hypermetabolism is seen within that lesion and in that node. So what about the image interpretation? Well, it's really important to have a perfect imaging protocol to make sure that there are no artifacts or limitations that are affecting how you're looking at your PET CT. So some of the important things in pursuing a very perfect imaging protocol is that patients have to fast. What we want is that when the patients come to the facility, we want to make sure that they have a fast so that when we inject them with radioactive glucose, that's what's going to actually go into the cancer cell and not endogenous glucose. It's always a bit of an issue when you're dealing with diabetic patients on metformin or insulin. So we have a very special protocol to deal with that because we don't want a lot of, a significant amount of glucose on board those patients. We don't want any patients to exercise prior to imaging. It's important to have good hydration. And what we do is we inject the pharmaceutical in a very quiet environment. We wait for about 60 minutes. And then what we do is we put them into the PET scanner and we take our images. So these are just some common things that you can see on PET CT. So this arrow is just demonstrating the larynx and the vocal cords. And this patient had hypermetabolism in the vocal cords. Is that normal versus abnormal? It's normal. You don't want to see that. And basically, this patient was on their cell phone prior to having the PET scan done, and phonation caused increased metabolism within those vocal cords. Again, important to have fusion imaging and have CT because then you say it's not localized to a lymph node, it's actually localized to the vocal cords and it's physiologic. When I'm viewing a PET scan, I have a special workstation that's able to triangulate and fuse the two images together and allows me to generate SUVs. So this is a patient who has a esophageal lesion, which is hypermetabolic. This was in keeping with a primary malignancy of the esophagus. And again, you can look at it in multiple planes. So the sagittal, the coronal, and the axial plane. Just want to show you quickly what a normal PET scan looks like. So this is a MIP image, which rotates around. So it's a 3D volume. And basically it's looking at the maximum intensity in each voxel that we're seeing. So normal to see lots of activity within the brain. This is tonsillar activity, cardiac activity, liver, spleen, renal activity. The FDG is excreted into the kidneys and to the bladder. So when we look at our PET scans, we can scroll through those images. And again, this is a normal PET scan, so lots of activity within the brain. Again, activity within the myocardium, normal to see. Activity within the liver and spleen, normal to see. FDG is excreted by the kidneys, so you can see it within the renal collecting system, and then you can also see it with the bladder. And again, we can look at our images also along the axial plane as well. So just scrolling through these images. Okay. So whenever we look for a lesion, we want to sort of describe the lesion, and the lesion can be described visually or qualitatively. We can assess or we can assess that lesion in a semi-quantitative fashion or quantitatively. So most of the time when we're interpreting PET scans, we look at things qualitatively and we compare them to the blood flow activity. And we also look at them semi-quantitatively, which is what's called an SUV. So this is a patient who had a lung lesion in the right upper lobe. You can see it up here. On your PET scan, it's FDG avid. On the co-registration, again, it registers as well. Again, lesion in the coronal plane, FDG avid. This is the normal blood flow activity that we're seeing within the heart. This is our MIP image. So hypermetabolic lesion in the right upper lobe. This is a high probability for malignancy. So again, as I mentioned, not only do we look at things visually, but we also look at SUVs as well. So this is and that stands for standard uptake value. And what we're looking at is we're looking at a region of interest placed over a lesion and comparing the amount of activity within that region over the amount that we've injected in a patient. So that's called an SUV, and you'll see that. And under many circumstances, SUVs that are higher are more concerning for malignant processes. So again, this is the normal, PET scan, and these are some normal SUVs that you see. So we see usually the SUV of the blood flow activity, which is basically a standard reference, is between 2 and 3. So anything above sort of 2.5 and 3, you get concerned that there's some sort of pathologic process going on. And you can see all the other different SUVs that we're seeing as well in the body. Liver's a little bit higher. Spleen is usually a little bit less than liver. Again, we're seeing this renal activity as well, activity within the bladder, and activity within the brain. This is a really important slide because it goes to show you that not everything is FDG avid. So if you have a lesion that's pathologic, that's malignant, there are situations where it's not going to uptake radiotracer and you're going to have a false negative scan. So usually melanoma, Hodgkin's lymphoma, non-Hodgkin's high grade like B-cell, colorectal, lung cancers, esophageal cancers, head and neck sarcomas, those tend to be quite FDG avid. So really easy to pick up on PET scans, provided that they're large enough size. And then you have kind of like the medium ones, which sort of have SUVs in kind of the 4s, 5s, and 6s. So like pancreatic, cervical, renal cells, breast as well. That can be kind of the mid-range. And then finally, you can have those cancers which are not FDG avid, where FDG PET is not really a great tool. So lobular breast is not great, mucinous, very well-differentiated prostate, ovarian, hepatomas. Those are not FDG avid. So you may have a lesion, you may want to determine what that lesion, how it's functioning. But when you do your PET scan, those lesions aren't going to be hot. So you still have to have a good understanding that even though something looks morphologically abnormal, but is metabolically benign, looks benign, always look at the morphology of the lesion. And what are some false positives we can see with PET? Well, when there's infection or inflammation, there's lots of macrophages. Macrophages like glucose, they like FDG, so that can give a false positive result. If you have muscle uptake, and that's in patients who are poorly prepared, they can have FDG uptake. There's a brown fat, which that keeps us warm. It's a very metabolically active. It's got lots of mitochondria that can also have FDG uptake. And patients who have had surgery or radiation, because of the inflammatory response, those patients can also be have FDG uptake. And you need to know when surgery was done or when radiotherapy was performed to be able to basically determine, is this something that's related to inflammation, or is this something that's more different pathology, such as malignant. So this is a patient who has multifocal parenchymal opacities in both lungs. It's the diffuse process. You do your PET scan, and it's hypermetabolic. And so this is not cancer. It's not malignant. This is pneumonia. And looking at the morphologic appearance, it looks like pneumonia. It's hypermetabolic, so it's just acute active pneumonia. This is a patient who has lots of metabolism symmetrically throughout their muscles. So you can see it within the traps, within the arms, obviously within the rib cage, in the glutes, and in the calves. And so again, this is muscle activity, and this is you tend to see this if patients are poorly prepared. They eat before their scan, and they tend to have lots of activity within their muscles, and that decreases the sensitivity of the PET scan. Another PET scan of a patient who has hypermetabolism, sort of in the supraclavicular regions, within the superior mediastinum, in the paravertebral regions, and it's localizing to fat. And again, here's another patient, sort of supraclavicular fossa, symmetric. You see that's where the FDG, the hypermetabolism, is going. It fuses appropriately. And so this is brown fat. And this is a patient who had a radiotherapy for a lesion within the mediastinum. If you look at the CT scan, there's this really geographic brown glass density in the lungs and its paramediastinum. When you do your PET scan, it's hypermetabolic. You see it as well in the MIP images as well. So this was in keeping with post-radiation changes. So very typical appearance on CT, and easy to see why it's FDG avid on the PET scan. It's really important that size does matter with PET. So we have very small lesions, less than a centimeter in size. Those lesions cannot be FDG avid because they're just below the limits of PET resolution, and it's very difficult to characterize them accurately. Obviously, certain neoplasms are not FDG avid, well-differentiated tumors, low-grade tumors, tumors that grow very slowly are not FDG avid. And so you have to basically understand the morphology a bit more and use that when you're interpreting the studies. Mucinous lesions, whether it's ovary or whether it's related to colorectal, are also, they tend not to be too FDG avid. So that's another cause for a false negative. And poor patient preparation, where you're driving all the radioactive glucose into the muscles, that can be another reason why you have a false negative study. So PET scan on a patient with the ground glass opacity in the right lower lobe, which was growing over time, it doesn't look like it's hypermetabolic. Certainly, it's less than blood flow activity. When you look at the SUVs, it's like under 1. So you wouldn't want to say this is benign, but basically this has been slowly growing over a long period of time. And even though it's not hypermetabolic, this was in keeping with adenocarcinoma in situ. Whenever you do PET scans, there's always serendipity, where you tend to find other lesions or other things accidentally, which sometimes you don't expect. So these are some serendipitous findings in the world. The slinky was serendipitously found. Rogaine, which is minoxidil, which is a potent peripheral vasodilator used for hypertension. They gave it to patients. They found that they were growing hair. So now that was a serendipitous finding of Rogaine. Apparently cornflakes was also serendipitously found. Uranium radioactivity was also a serendipitous finding by Henri Becquerel many years ago. Viagra was also serendipitously found. Again, used was pharmacied by Pfizer and was used as an antihypertensive and for angina, and it had other effects or other stronger effects. So that was a serendipitous finding. And apparently, the chocolate chip cookie was also serendipitously discovered. So this is a patient who had a breast cancer, which is actually not appreciated on these images. So here we're looking at liver, we're looking at spleen. This is stomach activity, renal activity here. So you see it's excreted into the kidneys, and then there's cysts. This is bladder, and this is rectum. And rectum, there's hypermetabolism in the rectum, and this was in keeping with an instantly found rectal carcinoma. So which is quite hypermetabolic. So always, when you're looking at PET scans, you're always looking for these incidental findings, and those things tend to be further investigated. So who needs a PET scan? So I'm just going to go through some very common indications for PET over the next 10 minutes. And then what I'll do is I'll just show or 5 minutes, and then I'll just show some case studies that we have from the Bahamas, which are really impactful and interesting. So why do we use PET in oncology? Anatomic imaging CT is limited by looking for tissue that might be functionally abnormal, but looks morphologically normal. So you see a lesion, you see a lymph node. Lymph node is sub-centimeter, under 10 millimeters. And you think it's a normal node, but then when you do a PET scan, it's hypermetabolic and it's pathologic. So you can have normally looking findings on CT, but there's an underlying pathology, and that's where PET comes in. And PET CT is very useful in lung cancers, lymphomas, colorectal carcinoma, esophageal, melanomas, head and neck, and breast. So it's important. PET scans are used for diagnosis, for staging. They've got prognostic value. We also use PET scans to risk stratify patients and to assess responses. You know, PET now is being used to change treatment responses based on how patients are responding. It can be used for surveillance, restaging, and treatment planning. So here are just some quick cases to show. So for diagnosis, it can detect occult primaries, and it can verify lesions, which maybe you're doing biopsies and they come back negative, but they look ominous, and you do a PET scan, and it gives you a better idea that it's something that's pathologic and malignant. So again, similar patients, a 52-year-old male patient with a pulmonary nodule. They did FNAs, it was failed. Again, lesion in the right upper lobe. It's hypermetabolic. This has a high probability for malignancy. This was resected and was a primary non-small cell lung cancer. This is a patient who had a pathologic necrotic cervical node in the neck. They had done an endoscopy, and they did some biopsies, and they couldn't find a primary lesion. We did a PET scan, and if you look at here, the tonsil here is a little bit fuller. On the emission scans from the PET, this lymph node is hypermetabolic, adjacent to where it's necrotic, and this tonsil is very hypermetabolic. So the primary was actually identified in the tonsillar tissue, which was rebiopsied and positive. And again, that node was hypermetabolic. And obviously, if you can find the primary in these patients, you're better able to direct therapy, so that decreases the morbidity associated with the treatment plan. PET scans are great for staging patients. They can upstage or downstage lung cancer patients about 10% of the time. It's probably even higher. And also lymphoma, upstaging or downstaging between 10 to 40% of the time, based compared to CT imaging. So this is a patient with a lung cancer. So there's a lesion in the right upper lobe. It's hypermetabolic. This patient on CT was only in early stage. There was hilar lymphadenopathy that was identified. So we do our PET scan. We see the lesion here. These are hilar lymph nodes here. More hilar nodes, a paratracheal node that was small, 5 millimeters. And then there was nodes on the contralateral side, which you see up here, prevascular lymph nodes. So this basically changed the patient's staging from early to late stage, and obviously affected treatment plan. This is a patient who had lymphoma, and the disease was within the lower neck. They did a PET scan and found also that there was a small prevascular lymph node, less than 10 millimeters, which was hypermetabolic. So this PET scan changed the stage of this lymphoma patient from a clinical stage 1 to a stage 2. PET scans are really useful for treatment response and evaluating response to therapies. And you can see changes in PET scans before you can see morphology. This is a patient with a GIST tumor, which is quite hypermetabolic. On a post-therapy scan, the tumor looks larger, so you're worried, is this progression? But actually, it's not hypermetabolic. So this is actually a good response to therapy. And these are some issues that you can see where there are changes in morphology which appear ominous or abnormal. But when you do your PET scan functionally, there's no activity, so there's no hypermetabolism. So this has been a great treatment response. And this is just a quick slide to show you that this is a patient who had a GIST tumor. I mean, the disease is everywhere, liver, there's peritoneal disease. But just after 24 hours of giving a Gleevec, you can actually see changes in hypermetabolism within disease at 7 days, at 2 months, and then at 5 months. And these changes in function actually precede any changes you see in morphology. So really, really important to use. PET scan is very important for the early diagnosis, where it can detect things that are functionally abnormal, but where there's no changes in morphology. A big one is colorectal carcinoma, patients with elevated CEA but are imaging negative. Again, this is a 48-year-old patient. He had pelvic exenteration, an ileal conduit, which is here. Tumor markers were rising. CT was negative. This is where the anastomosis is. It was like either an APR. And there's focal hypermetabolism at the anastomotic site. So this is where the recurrent disease was. PET is also very important for treatment planning. Again, this is a patient who had a lung carcinoma, has complete collapse of the lung on CT. Like, where is the disease? You do a PET scan. PET scan is hilar. So when you're focusing your radiotherapy and your treatment plan, you can concentrate on the area where there's pathology, so you decrease the morbidity in the other areas. Before we go on to the PET CT scans in Bahamas, just some ice hockey factoids. I just want to compare a little bit about Canada to the Bahamas. So I was looking to see how many hockey rinks there are in the Bahamas. In Canada, we have over 7,000. And in the Bahamas, I think there are might be 2. I think it's synthetic ice, one at one of the resorts and one at Port Hope. I was looking to see how many national hockey league players there are in the Bahamas, from the Bahamas. In Canada, we have over 25,000 that have actually played in the NHL. And actually in the Bahamas, there is one whose name is Andre DeVoe. He was born in Freeport and he played for the Toronto Maple Leafs, ironically, back about 10 years ago. And then again, I said this is the holy grail of Canadian sports, is the Stanley Cup. And I just want to see like how many Stanley Cups have people in the Bahamas won versus the people in Toronto since 1967. And this is where we're the same, 0 in the Bahamas and 0 for the Toronto Maple Leafs. So we have something in common in terms of no trophies in hockey. So now I want to talk, for the next 10 minutes, I want to talk quickly about PET CT in the Bahamas, which has been a real pleasure to work with the staff there. So this is the facility, waiting room we have here, obviously hallway. This is our radio pharmacy where we deal with the doses we're getting. And after we deal with dose, we put patients in these rooms so that they can their uptake rooms. So that's where they go for 40 to 60 minutes. And then we put them in the PET scanner. So what are some of the pathologies that we're seeing in the Bahamas? So like I would say 1, 2, 3 is breast. Lots of breast cancer, lots of advanced disease. Something that we don't see as much here in Canada. Probably colorectal and gastric are kind of in there as well. Melanoma, myeloma. And less things to see on these PET scanners from the Bahamas in terms of pathology, renal cell, pancreatic, prostate, sarcoma, and very little lung and lymphoma. And the reason why I highlight lung and lymphoma is like lung and lymphoma in Canada is probably like 60-70% of all PET scans. And in Bahamas, it's sort of like 1 to 2% of cases. So different pathology mix depending on different populations. So let's show some cases. I've got some great cases here. So this is a 49-year-old patient with a left pleural biopsy, which was consistent with clear cell carcinoma. So the question was, where's the primary? Is it GI? Is it renal? So PET scan shows a hypometabolic area within the brain. There's multiple hypermetabolic mediastinal lymph nodes. This is paratracheal, prevascular, periortic. There's lung lesions, multiple lung lesions, pleural lesions. There was actually a lesion within the bone near the sacrum. And then there was a mass lesion within the kidney, which was hypermetabolic and necrotic. So this is so the primary was left kidney, and there are mets to the brain, the pleura, the lung, and the bone. So very extensive disease. And this shows where this is just an example where PET is a really great tool for looking at unknown primaries, which probably have an incidence of between 1 to 7%. PET scan has really good sensitivity and specificity, and it also detects additional disease in about 31% of patients with an unknown primary. Another PET scan in a patient, so 49-year-old female patient with locally advanced breast cancer for staging. And again, there's this lesion in the left lateral breast, which is hypermetabolic. So that's the primary lesion. Small little lymph node. It's not hot, but it's small, and there's metabolism. And obviously, this is concerning for regional nodal disease. And then we also noticed a mass in the stomach, which was hypermetabolic. So we got primary cancer, regional adenopathy, and then we have a mass in the stomach. And so this was a patient who had lobular, locally advanced breast cancer, had an axillary nodal met, and had a second primary malignancy, which was gastric. And there's an association with this CDH1 mutation in patients with breast cancer, particularly lobular, and having a gastric malignancy as well. So in terms of PET scanning for breast cancer, it's not recommended for the routine use and diagnosis because there's false negatives. So lesions that are less than 10 millimeters, they may not be detective. If you have lobular or tubular cancers not well detected, or DCIS, and you can have false positives. So anything with its inflammation, mastitis can be FDG avid, and also fibroadenomas about 10% of the time can be FDG avid. PET is primarily used in patients with locally advanced breast cancer, and it's shown to change the clinical stage in up to 36% of patients. And now there is some use of, there's some literature to support the use of doing PET scanning in patients with earlier stage cancers like 2Bs, and also patients under the age of 40 who have high risk for aggressive tumors. This is a 44-year-old male patient for restaging colorectal carcinoma. The patient was going to have high PAIC. This is a lesion in the rectum, which is FDG avid. There's all this disease within the peritoneum, so this was carcinomatosis. There's also some extraperitoneal disease as well. But there were these liver lesions on CT that were just like, we weren't sure if they were cystic or solid, but they're FDG avid. They've actually got rim hypermetabolism, and so those were in keeping with hepatic metastases. So this is primary colorectal, had diffuse peritoneal disease, had hepatic mets, which is a relative contraindication to having high PEC. So FDG is indicated in patients with colorectal carcinomas to detect hepatic and extrahepatic disease. It's not very good for detecting regional nodes because they can be obscured by the primary lesion, or detecting small liver mets less than a centimeter in size. It's got great use in looking for restaging, so patients who have rise CEAs but are imaging negative or equivocal, for preoperative evaluation of patients who have hepatic disease, but they might fulfill criteria to have resections. And it's really good at distinguishing local recurrence from scars. So this is a 71-year-old patient for restaging pancreatic cancer. Lesion is here, so it's there's a recurrence, but there was also a breast lesion as well. Is this serendipitous? Is this a primary breast cancer as well in this patient with pancreatic recurrence? They did a biopsy on the breast lesion, and it was actually a pancreatic met. Haven't seen that before. FDG has sort of reasonably good sensitivity and specificity in the assessment for pancreatic disease. It's not good for small lesions. It's got a very low detection rate for regional lymph nodes. Again, they could be obscured by the primary lesion. And PET is not as good as CT for looking for liver metastases. This is a 56-year-old female patient who had a mastectomy in 2008 and 14 and was for restaging. And if you look at the MIP image, like this patient is just riddled with bony metastases. It almost looks like a bone scan. So diffuse mets in the bones. There was also disease within the prevascular space adenopathy. So this is diffuse bony metastases, it's recurrent disease, there's pulmonary disease, nodal disease, extensive bony mets. And just so this is a really important pearl about PET-CT with bony mets. Skeletal mets are also the most common site for the initial presentation of metastases in breast. They're usually sclerotic. And PET is not the best for sclerotic lesions, it's best for lytic lesions. It has a much lower detection rate for sclerotic lesions. What the literature says is that FDG should not substitute a bone scan in patients with breast cancer or at high risk for mets, but should be used complementary with bone scintigraphy. This is a patient, a 69-year-old male patient with a brain met, which you see here, and a scalp lesion, which was diagnosed as an atypical fibroexanthoma. We did our PET scan and we see there's actually a pulmonary nodule, which is FDG avid. There's also a buttock nodule, which is FDG avid. So this patient's got a diffuse process going on. And further history, the patient had a history for melanoma. And so this was melanoma, metastatic disease. There were brain mets, pulmonary mets, soft tissue mets in this patient. PET scanning should not replace sentinel node scans for patients with melanoma, but it's superior to conventional imaging for looking for distant disease, although not as good in the brain and liver, where MRI has a higher sensitivity for detection, and it's very good for recurrent disease as well. Just a few more cases. A 41-year-old female patient with locally advanced breast cancer was a T4N3MX. So you see here's the disease, hypermetabolic disease. It's actually multicentric disease. There's axillary adenopathy, which is hypermetabolic. There's a small little pulmonary nodule, which is hypermetabolic, which is a MET. There's a sclerotic metastasis, which is not hypermetabolic, which is again a false negative. And the patient had a thyroid lesion that was hypermetabolic, which was an incidental serendipitous finding. So this patient had multicentric breast disease, they had regional nodal disease, they had pulmonary mets, they had bony mets. Again, not sclerotic, not FDG avid, and they had a thyroid lesion. And whenever you see uptake in a thyroid lesion, up to 40% of those patients have well-differentiated thyroid carcinomas. So important thing about PET scanning is that it's not good for staging the axilla. It can't replace a sentinel node or surgical dissection because we see small, because it misses micromets and it misses small lesions that are 10 millimeters. This is a patient with MGUS, monoclonal gammopathy of uncertain significance. We did our PET scan. No disease really within the marrow space, except there was focal hypermetabolism within the posterior ileum on the left side. So is that actually a marrow disease? On further assessment and talking with a referring clinician, this patient had a recent bone marrow biopsy, so that was a false positive. And in this patient, there was no metabolically active marrow disease. PET scan is pretty good for identifying patients who have MGUS or smoldering myeloma when you're looking for active disease. And if you see active disease, those patients either have active myeloma or they're prognostically going to have a higher risk for progressing into myeloma. Two more really cool cases here. 72-year-old female patient with metastatic melanoma to the groin. No prior primary lesion was identified. We do a PET scan. There's a brain met. There's a lung met. There's the groin lesion. And actually in the vulva, there was also, in the mons, there was a hypermetabolic lesion. So that was where the primary state of disease was. Patient was put on immunotherapy, and all the sites that we showed resolved, but then they developed more hypermetabolism within their articulating surfaces. They developed higher adenopathy. They also developed hypermetabolic skin lesions and soft tissue lesions. So in the follow-up scan, there was resolution of all the disease. They were clinically doing well. And what they developed on immunotherapy was this sarcoid-like reaction or autoimmune inflammation. And that's been described where they get this, you get pancreatitis, thyroiditis, dermatomyositis, and it's related to these new immunotherapy agents that are being used for treatment. So it's always important to be on the lookout for that. And this is the final patient, is a 39-year-old male patient who was for restaging colorectal carcinoma. Patient had a prior right-handed colectomy and has diverticulitis. And here's a big diverticulum. There was surrounding in the sigmoid colon, and there was focal hypermetabolism favored to represent diverticulitis. But patient also had a lesion within the right kidney, which was solid. I mean, you see it right here. It's FDG avid, and this is most in keeping with a primary malignancy. So this patient did not have recurrent disease. They had diverticulitis. They had a right renal mass, which is presumed to be cancerous. And on further clinical evaluation of the patient, they had Lynch syndrome, and this is a very common cancer syndrome, and it predisposes patients to having multiple malignancies, including GI and renal cell. So really, a really amazing case. So in summary, I've discussed the basic principles of PET-CT, talked about radiochemistry, biology, talked about the technology limitations. I summarized some of the main oncologic indications, so diagnosis for unknown primary, staging, lung, breast, and locally advanced disease. The restaging of patients, certainly there's a multitude of disease processes, oncology processes that they can do. PET can be used for surveillance imaging, particularly in patients which are biochemically positive or imaging negative or equivocal, and can also be used in treatment planning. And then finally, I've just demonstrated through a case series from the Bahamas that there's been a significant clinical impact in having PET scans performed locally. I hope you enjoyed my presentation, and I'll open it up to a few questions if there's time.
Thank you very much, Dr. Freeman, for that presentation. Once you start talking about, nuclear medicine, it starts bending the mind, but thank you for trying to break it down and make it easily accessible for us to understand. And thank you for those fun facts and trivia. So we will get going with our questions, and I see we have one here. If prostate not so FDG avid, what is the best investigation for prostate cancer? We have a high number of prostate cancer in the Bahamas. What is the best investigation we can do here in the Bahamas? Is it PET, MRI, and diffusion weighted study? We don't have PET PSME.
Yeah, I mean, that's a great question. I mean, I agree, FDG is not a great tool for staging or restaging of PET prostate cancer. It's only good for, I would say, patients who have sort of high-grade lesions, high Gleason score lesions, rapidly rising velocities in PSAs. I mean, PET scan is useful. I think it's, you have to stick with your bread and butter imaging. So CT imaging, looking for, nodal disease and distant disease. MR imaging, looking at, primary disease and looking for, staging the local disease. I think those need to be your kind of, the bread and butter modalities that you need to use. And then PET you can use sort of, I would say, as sort of problem solving, but it should not be used as kind of the primary modality for restaging of prostate, particularly without having, better radioisotopes like PSMA available.
Thank you. An excellent talk, Mark, and that's from Nimu Ganguly. And so, Dr. Halliday, can we please unmute Dr. Ramphal? And while we wait for Dr. Ramphal to be unmuted, I have another question here. What is the ideal time interval to restage with PET following radiation?
So great one. So, normally with radiotherapy, again, I would say within, 6 weeks. After 6 to 8 weeks, I think it can be used, particularly at the 3-month interval where you're going to have significantly decreased false positive. That's probably the most ideal time. But many situations when you want to use PET scanning to kind of help you in the management of your patient, 6 weeks is sufficient. So the way I look at it with PET scanning and treatment changes is that 6 weeks after surgery, 6 weeks after radiotherapy, and 2 weeks after chemotherapy. And for chemotherapy, what you'd like to do is before they start the next cycle of chemo, you want to do your PET scan. So that's those are sort of the optimal times to be able to do your PET imaging. If patients have had chemo radiotherapy, you need to wait a little bit longer, over 3 months because of the effects of that treatment, combined multimodality treatment in those patients.
Thank you. And Dr. Sinqui has a question. Thanks for the presentation. Given the short half-life and challenges with transportation, what is the approximate amount of cases that have to be canceled or repeated?
So that's a good question. So, I don't have the actual detailed numbers, but anecdotally it's very few. So what you end up doing, because of all the supply chain, which can be tenuous, like obviously the issues when you don't get your FDG, you have to cancel patients. And, I would say that it doesn't happen very often. And I think the Cardinal has been really reliable in terms of its delivery. But what we end up doing is you end up actually, ordering more dose than you need, so that if there are any delays in the logistical transportation of the agent, that doesn't affect your injections because you have enough dose to give to the patient, at the end of the day. So, it takes a little bit of, administrative work to make sure you have enough dose. But the supply chain obviously, has been actually pretty good. It would be, be great if there was a cyclotron in a pharmacy in the Bahamas, because that would ensure the best supply. But overall, I think there's been reasonably satisfactory transit of that tracer from Florida to the facility. So I've been really happy about that delivery.
Thank you. And Dr. Ramphal, I believe, is unmuted. Dr. Ramphal, you can go ahead with your question.
Okay, thanks, Dr. Freeman. Can you hear me?
Yeah, I can hear you.
Yes, go ahead.
Okay.
We can hear you.
Dr. Freeman, that was a great presentation on many points. I really enjoyed it. A question and a comment. Question is, related to a patient, for example, that I have right now with previous history of breast cancer and subcentimeric nodules, which were reported on PET as being too small to be reliably analyzed by PET.
Yeah.
Now, we've scheduled her for a biopsy, but in a patient in a similar situation who does not want to have the biopsy, what would be at this point in time, what would be your recommendation for further investigations in such a situation?
Sure. So you're probably talking about pulmonary nodules, right?
Yes. Sorry.
Yeah. So I see this, here, and I see this in the Bahamas as well. Is like, when you have a nodule that's less than 10 millimeters, even if the pathology is aggressive, they may not be FDG avid, particularly the ones that are 2 millimeters or 5 millimeters. And another problem you have is that, too small to characterize. So when you see them, they're not hot, but you don't know. And then even if they're hot, sometimes you don't know if they could be inflammatory. They could be centrilobular nodules. So what I would say is the best thing to do is actually follow them with CT, like diagnostic CT. If they're growing over a period of time, then obviously they're more concerning. That's not to say that you can't use PET as an adjunctive imaging modality for those, but with subcentimeter pulmonary nodules, and you want to know if they're metastatic, CT is a better tool. That being said, PET might, if you did a PET scan in that scenario, and again, it shouldn't be the primary follow-up modality, it might identify another site, like a lymph node in the axilla or somewhere else that would, help you in the management of your patient. But in general, small pulmonary nodules are not really well characterized or followed with PET, and even when they are hot, and if it's a one-off PET CT, sometimes you don't know because they could be inflammatory.
Okay, and thank you for that. And my comment is that there's another Bahamian professional ice hockey player who played for the Winnipeg Jets. He played for the Jets in the late 1970s and the 1980s. Winnipeg Jets. His name is John Bethel. He's an acquaintance of mine, and so I know he was in the NHL. And I have.
Oh, that's great.
So you can add him. You can add him to your census.
Yeah. I would. And what about those hockey rinks? Like, is there synthetic ice in Bahamas? Like I saw.
I'm not sure about that.
So,
but if there's ice, it has to be synthetic.
Yeah, I get it. So, but that's great. There seems to be lots of connections between the Bahamas and Canada, especially for I know a lot of many of you are trained or have children that are sent up here for universities. So it's great to see that linkage between the islands and Canada.
Excellent.
Yes, thank you, Dr. Fallon. Thank you, Dr. Freeman, for that. And so we have another question. What is the cost and possibility to get a cyclotron here?
So the possibility, I don't know. I mean, that's something that, someone local will be able to say, but like cyclotrons, you can get a mini cyclotron, which just produces FDG, and it's about $1.5 million to $2 million. But then if you want a cyclotron that can produce PSMA, and these other agents, which could be very useful and much more specific for certain, you're looking at $5 million plus. And then the operation of these facilities is not cheap. So you have a capital cost of, for a full-blown cyclotron might be $5+ million. It might cost you, another $1 million a year in operations of that facility because you need a radiopharmacist, you need a chemist, you need personnel. So it's not an inexpensive endeavor.
Yes, thank you. And our final question is, are there any advances with hybrid PET CT using tagged white cells or Tec-99 in lieu of FDG?
That's a good question. So you don't need to use hybrid PET CT. You can use hybrid SPECT CT. And so I'm not sure the type of technology you have down, in your jurisdiction, but you can tag patients with, white cells with technetium or indium, and you can do SPECT CT where you do the nuke med study and then you fuse it with the CT for better anatomic localization. And that's something that's relatively commonly done up in Canada, because we have these cameras that can do, just like a PET CT, they're SPECT CTs, and they can do general nuclear medicine and fuse it with CT images as well. So it's possible if you have the technology down there, and it's available.
Well, thank you. And Dr. Freeman, from looking at the pictures of the equipment that you posted, are there any weight restrictions for these tests?
Yeah, I mean, there's always weight. So usually these tables, they can tolerate sort of 350 and below. So I would say for 99.9% of the time, you're able to do these PET scanners. Obviously you're always a bit more worried with the heavier weight patients, and sometimes they say that these tables can support up to 500 pounds. But I would say sort of 350 and below, you're relatively safe to be able to do a study on the PET scanner.
Well, excellent. Thank you very much, Dr. Freeman, for joining us today. Do you have any final comments before we close the meeting?
No, I just want to thank, Dr. Francis and his team for, obviously setting up the facility and including me in the interpretation. I've really enjoyed interpreting studies and connecting with physicians and reading these cases. Like, as I mentioned before, initially, they're very challenging cases. I really have, the healthcare, system is, challenging to say the least. And I think that these cases that I'm seeing are really unbelievable. But I think the level of physician care and the compassion that physicians have in the service delivery to these patients is pretty unbelievable. And what I would say is I've really enjoyed working with the group down there, and I hope to continue to do so. And I think you're doing a great job with the resources that you have in providing the best cancer care diagnostics and therapeutics to your patients. So a real kudos to the work that's being done on the island. And so I'm really impressed by it.
Well, thank you, Dr. Freeman. Thank you for joining us and sharing with us. Enjoy your day, and hopefully the Maple Leafs bring it home one day.
Yeah, we'll do. Hopefully. Thank you so much, everyone. Have a great day. Thank you.
Okay. And thank you very much to our audience. Remember, the link for the feedback is in the chat, and the enrollment key is all lowercase imaging. Thank you very much to Dr. Halkides for helping to arrange this meeting, and to Dr. Halliday, our technical staff, as always, for making the meeting happen. And please join us the last Friday of July, which is the 30th, and that will be our final meeting for the summer, and then we will recommence again in September. So everyone have a good day, and thank you very much.